Hello, everybody. Welcome to another session of CellTalk, where we will be talking all about science. Today, we have with us Dr. Vijay Padul. Vijay is the senior scientist at Renix and leads bioinformatics, genomics, and next-generation sequencing research-related activities. He is currently working on the neoantigen cancer vaccine pipeline at Renix Life Sciences. Vijay holds a PhD in Life Sciences from TMC ACT REC, Homi Bhabha National Institute, Navi Mumbai. His PhD study focused on cancer genomics. Previously, Vijay has worked as assistant professor at graduate and postgraduate degree college. Welcome, Vijay, to CellTalk. I hope you can now take over the session. Over to you, Vijay.
Thank you, Dr. Chiku. Hello, everyone. So for today's CellTalk Journal Club, I have selected this research article. The title is a phase 1b/2a trial of 9 repurposed drugs combined with temozolomide for the treatment of recurrent glioblastoma. And they have called this treatment regimen as CUSP-9v3. Original authors are Mark-Erik Hallatst and others. And I'm presenting it. And my affiliation is bioinformatics scientist at Renix Life Sciences. So phase 1b/2a trials, these are conducted to assess the preliminary efficacy and safety of the drugs. So in this research article, they have conducted this clinical trial to assess the safety of 9 repurposed drugs in recurrent glioblastomas. Okay, so among the topics those were given for the presentation, I have selected the repurposed drugs in GBM category for this. The journal in which it was published is Neuro-Oncology Advances. The impact factor is 10, and it was published in year 2021. To give the introduction or background of this research article, then it will be it is glioblastoma. It is one of the most challenging malignant tumors in all of the oncology. And these tumors are very aggressive, they grow very rapidly. And along with that, these glioblastoma tumor cells, they can also adapt to chemotherapy and also after a while stop responding to radiation therapy also in some cases. So therefore, these glioblastoma tumors are generally considered as very difficult to treat, and survival in this patient is also very low. Despite different approaches that have been employed, the survival hasn't increased beyond much a limit, irrespective of whatever strategy that has been used. Now, this research article, which explains the clinical trial, it aimed to identify safety of repurposed drugs or combination therapy, which is targeted against the glioblastoma tumor cells. So this research, it has impact on different cancer types, specifically brain tumors, glioblastoma, and other gliomas such as recurrent astrocytomas and recurrent oligodendrogliomas. To give a general background of this glioblastoma and why it is very difficult to treat and what approaches can be used. So these are some topics or points that I would like to highlight. So glioblastoma is the most common and most aggressive primary malignant brain tumors in adults. And despite therapeutic interventions, the glioblastoma prognosis remains very poor, as most patients die within 12 months after diagnosis. So as we discussed earlier, that these glioblastoma cells, they are very aggressive. They grow very diffusely in the surrounding normal tissue of the brain. And therefore, there is very little time for therapeutic interventions in which we can stop the progress of these malignant cells into the normal area. So the current standard treatment for glioblastoma, it is the neurologically safe maximal surgical resection of the tumor. So wherever in the brain that tumor is occurring and it is growing, so the first surgical intervention is to attempt to debulk as much of the tumor, take it out of the brain and debulk it so that the brain functionality is not affected because of the growing mass of the cells in the tumor. And then after surgery, the next approaches are irradiation, that is radiation therapy and chemotherapy. Radiation and chemotherapy can be given together, or only chemotherapy can be started. Most commonly, temozolomide is used as a chemotherapy drug. Notice temozolomide, it acts as an alkylating agent. It alkylates the DNA in the cells. It methylates at the O6 guanine of the DNA. So this hypermethylation, it affects the normal functioning of the cell, and it results into the death of the cells. So it is mostly active in the growing cells and rapidly dividing cells. So it is also acting on the normal cells also. So it has its side effects associated with also. And this treatment strategy it results in the progression-free survival of 6.7 months. Progression-free survival is whatever tumor that has been resected from the brain. How long does it take for that particular tumor to grow and reappear in that particular place or in the surrounding area? So that is just 6.7 months. And overall survival of the patients is 16 months. And two-year overall survival is 30.7%. That means only 30.7% of the patients will survive till year 2. And most of the patient will die by the month of 16 months. Now, this poor survival is due to diffuse nature of the tumor. Now, where cancer cells migrate and start growing to the surrounding normal part of the brain and affects the normal functioning of that part of the brain. And this also leads to the recurrence of the tumor, which usually takes place within a year after initial treatment. So recurrence is more common in glioblastoma because of the high growth rates of these cells. So recurrent cancer cells, they evolve and develop resistance to drug therapy. So this is another level of difficulty in treating these cells. As the cells are growing rapidly, also they, once you provide them chemotherapy with temozolomide or other drugs, initially few cells might die, but the remaining cells, they might acquire resistance against that particular drug, and that drug may not be useful further in resisting the growth of or arresting the growth of that particular tumor. So this is also one of the complexity. And what happens due to that is that the tumor, it becomes a heterogeneous mass of cells in which different cells have evolved differently against the therapeutic regimen that has been employed. Now, due to these reasons, glioblastoma is one of the most challenging malignancies to treat in all of oncology. Till date, not a significant achievement in treatment of this glioblastoma has been achieved. Now, next, as of now, there is no commonly accepted standard of care for recurrent glioblastoma. Like what treatment can be given to the recurrent glioblastoma? So glioblastoma, we have standard radiation therapy and chemotherapy, most commonly with temozolomide. But once it recurs, it no longer responds to the available therapeutic regimen. So, and again, till date, no therapeutic regimen has been proven to be effective against this tumor. As the dismal prognosis of the glioblastoma is related to the ability of glioblastoma cells to develop mechanisms of treatment resistance. So one way we can tackle this problem is by using multiple drugs simultaneously. As we have seen earlier, that the glioblastoma cells, once we provide them a single drug treatment, then many cells might avoid that particular attack, that particular target, and develop mechanisms to sideline those particular pathways and grow differently and might result into the resistant cells. So one of the ways in which this can be tackled is use multiple drugs simultaneously so that there will be no margin for these cells to develop any resistance. They might develop resistance against one drug, but other drug might be effective. So in this way, multiple drug, if used simultaneously, may be effective in the recurrent glioblastomas and the primary glioblastoma also. So with this background, we come to our original research article. So this Halash et al., the authors of this particular research article, they proposed in 2013 a concept to treat the patients with recurrent glioblastoma, and they called it as CURSP, that is coordinated undermining of survival paths. So what they are aiming to do here is that there are multiple pathways that get activated into the glioblastoma cells, which lead to the aggressive growth of these glioblastoma cells. So if there are multiple drugs which target one or more of each of these pathways, then there might be a possibility that the growth of these glioblastoma cells might be arrested. So this group, they adopted a drug repurposing strategy. In our earlier CellTalk Journal Club, we have seen a drug repurpose strategy with a drug that is used to treat for diabetes. It is being used for treatment of cancer patients. So this strategy is being employed by these authors. Now, what are the present challenges here? So glioblastoma tumor is most difficult to treat. Glioblastoma cells grow vigorously and spread diffusely in the surrounding normal brain tissue. The glioblastoma cells develop resistance to chemotherapy as a result of cellular heterogeneity and resistant mechanism, and this further results into the recurrence of the tumor. Now, recurrence usually takes place within a year after initial treatment, and as we have seen that the overall survival of these patients beyond 12 months is very minimal. So there is very less chance for treatment of this recurrent patients also. So this is one of the major challenge. Now, next challenge is that for recurrent glioblastoma, no treatment regimen has been proven to be safe and markedly effective. There is no marked difference into the treated patients as compared to the non-treated patients. And also, a commonly accepted standard of care for the recurrent glioblastoma is not present. So to treat these patients, so that particular common standard of care is not available. So with respect to these challenges, they have set some objectives for this research. So the objective is to increase the efficacy of temozolomide chemotherapy by combining it with already marketed non-oncological drugs. So drug repurposing strategy is being used here. So they have identified a combination of different drugs, 9 in total. They have identified those drugs by literature search in which there is evidence that these drugs have an efficacy against cancer cells, either in vitro, in vivo, in cell line studies, etc. So they combined these different drugs and created a treatment regimen. And this research article, this research study, it aims to determine the preliminary efficacy and safety of the identified drug combinations that have been used. They call these drug combination as CUSP9V3, and this efficacy is to be judged in the glioblastoma patient population. So what is the methodology that they are following? So the first part was the selection of 9 drugs for the CUSP9V3 combination. So the CUSP9V3, it is an acronym for Coordinated Undermining of Survival Paths, combining 9 repurposed non-oncological drugs with metronomic temozolomide version 3. Quite a long sentence to read. So how do we understand this? So what they are doing here is they are combining 9 repurposed non-oncological drugs. So these drugs have not been used in an oncological setting. So these 9 repurposed drugs they have identified, and these drugs, these are targeting the survival pathways in the tumor cells. So these drugs will act against those survival pathways, and these are multiple drugs, and these drugs will assist temozolomide, which is the major drug that is being used. So this temozolomide at a low dose will be provided, and in addition to that, these 9 drugs will also be provided. So this approach, they are calling it as CUSP9V3. Now for this 9 drugs that have been identified. They employed a selection criteria. The selection criteria, it was the robustness of the preclinical data on the GBM growth inhibition, whatever studies that they have referred in which these drugs were used, either in a single or in combination. So there should be a robust preclinical data which suggests that these drugs are effective against the GBM cells and they cause the growth inhibition. And second criteria is that they should have a low side effect. As we are using 9 drugs and the 10th drug will be the temozolomide. Each of them will have their own side effects. So when we combine all of these, it should not result into overwhelming barrage of side effects. So therefore, each of these drugs should have low side effect. And then the third criteria is the clinical familiarity with the drug in its general medicine, non-oncology role. So these drugs have been are being used by the medical community to treat different diseases or different conditions. We'll see later what they are. So there should be clinical familiarity of the drugs to the physician who is treating them to assess its effect on the patient, and there is no adverse effect. So the fourth selection criteria is the availability as a generic and non-proprietary drugs. So again, generic drug and non-proprietary drugs means low cost will be achievable, and if proprietary drug is there, the cost might go high. So this is an important criteria for affordability of the treatment. Then a lack of predictable serious pharmacological interactions. Now, if you combine different drugs together, they might interact with each other and might produce some adverse effects on the health of the patient. So the drugs that are being selected, they should not have any predictable serious pharmacological interactions. So this criteria. So by meeting all these criteria, they have come up with these 9 repurposed drugs. So all of these drugs that those were selected, these drugs were just to have the robust anti-glioma or temozolomide augmenting effects. So these drugs, not only they had individually robust anti-glioma, but in some cases they also had the temozolomide augmenting effect. That means whatever effect temozolomide is having on the cancer cells for killing them, so it is showing enhancement of that particular effect. So what is this CUSP9V3 together? Now it comprises a low dose continuous temozolomide, and that is what is meant by the metronomic. So this metronomic temozolomide in low dose and continuous administration, and the level is 20 milligram per meter square body surface area, and through oral route, and twice daily, to be administered twice daily and without interruption. So this continuous treatment regimen, it is being identified as CUSP9V3. So these are the drugs, the 9 drugs selected, and this shows the characteristics of these drugs. So the drugs are aprepitant, auronopin, Captopril, celecoxib, disulfiram, itraconazole, minocycline, ritonavir, and sertraline. They have also seen the P450 inhibition characteristics of these drugs. So cytochrome P450, which works in the detoxification of the blood. So whether they inhibit them or not, to assess whether there will be an adverse interaction in the patient's body physiologically. They have seen that. So some of the drugs do show the inhibition to some extent, and some show weak inhibition. This column shows the half-life. So half-life ranges from less than 2 hours to 20 hours, 1 day in some cases. So these are the different pathways where these drug is targeting. So in different cases, there are different pathways which are getting affected. So aprepitant, it is a common drug which is used in cases of nausea and vomiting. And it is also used in cancer patients also. So it is affecting the NK1 receptors. So this has an ability to arrest the growth of the cancer cells. And this column shows what are the possible side effects. And assessing the side effects is very important in this case, because we are using multiple 9+1. 10 drugs are being administered simultaneously into the patient. So there are different side effects being noted here. So what are the different pathways that we find is the thyroidoxine and reactive oxygen species, STAT3, ACE, T1, matrix metalloproteases, so POX1, carbonic anhydride base, alcohol dehydrogenase, again the reactive oxygen species, EGP, flux transporters involved in the removal of xenobiotics from the cell. Then monocyte, this minocycline, it has a different approach. It inhibits monocyte macrophage microglia that contribute to the growth of the cancer cells. Again, in this case, mTOR, AKT, these are cancer-related pathways. These are also seen to be targeted. So multiple pathways are getting simultaneously targeted by these different drugs. So there will be minimal chance that the cancer cell will be able to bypass those drugs, and it is hypothesized that this treatment will be effective in arresting the tumor growth, at least not cause the recurrence. So here I have listed what are the common uses of these drugs and what it is targeting. So aprepitant, it is commonly used for nausea and vomiting treatment, and it is targeting the NK1, which is a growth stimulating element in the glioblastoma. And auronofin, it is anti-rheumatoid arthritis drug, and it inhibits the thyroidoxine reductase, which results in the increased intracellular reactive oxygen species, which causes toxicity to the cells and results in the death of the cells. Next, Captopril, it is anti-hypertensive drug, which is commonly used. This reduces the invasion, migration, adhesion of the GBM cell activity through soluble matrix metalloproteinase inhibition, MMP2 and MMP9 inhibition. Next is celecoxib. It is an analgesic, and it is shown to have anti-cancer properties related to the cyclooxygenase inhibition, and has encouraging result in combination with low dose temozolomide. So it is this drug, it is augmenting the effect of temozolomide treatment. Next is disulfiram. It is an alcohol deterrent. Now this is cytotoxic to different cancer cell types, and it is effective against GBM stem cell, and it is working through aldehyde dehydrogenase inhibition. Next drug is itraconazole. It is commonly used as an antifungal agent, and its anti-cancer activity is due to multiple pharmacological effects. One major is the effect on the autophagy in the GBM cells. So it is inhibiting that. So minocycline, it is used as an antibiotic. It has well characterized neuroprotective effects and reduces GBM growth and invasion. Next is ritonavir. It is antiretroviral, and in mouse GBM models with temozolomide, it is shown to be effective in inducing the endoplasmic reticulum stress, and thereby an effect against the GBM cells. Next, sertraline. It is an commonly used antidepressant, and it is targeting the E-glycoprotein at the blood-brain barrier. And it is also found to be safe to be used in GBM. So these are the different background information that they had about these drugs, and they combined these 9 drugs to create their strategy for treatment of glioblastoma patients. So coming to the study design, it is a phase 1b/2a trial. Now its aim is to examine the safety of the first 9v3 regimen with the 9+1 drugs, that is in combination with temozolomide, in patients with recurrent or progressive GBM. So the main patient area is the recurrent GBM. And the primary endpoint for this study is the dose limiting toxicity. It's the maximum dose which induces the most adverse effects or toxicity. That will be the endpoint of that particular dose that will be given. The secondary endpoints will be the best tumor response and progression-free survival and overall survival. The main aim of the study is not to study the efficacy of the CUSP-9V3 regimen against the glioblastoma patients. It is the major goal is to assess the safety, but is the secondary endpoint. That means some preliminary knowledge about the response against the tumor can also be gained through this study. So they have put a secondary endpoint here, that is the best tumor response and progression-free survival and overall survival. This study has been approved by IRB at Ulm University Hospital and German competent authority, this has been registered at the clinicaltrials.gov. The sample size for this study that was achieved was 10 patients. So how they have defined these different criteria. So dose limiting toxicity, they define it as any unmanageable grade 3-4 toxicity at the end of the second treatment cycle, or inability to receive at least 7 of the 10 drugs, all of them being given at greater than or equal to 50% of the target doses at the end of the second treatment cycle. So once that is achieved, it will be considered as a dose limiting toxicity, and that treatment, that dose will be stopped at that particular level. Best tumor response, the best therapeutic effect recorded from the start of the treatment until the last follow-up according to the response assessment in neuro-oncology criteria. So response assessment in neuro-oncology criteria, that is commonly called as RANO criteria, it defines what are the characteristics of the response in the neuro-oncological or brain tumor patients. And these are assessed generally through the radiodiagnostic methods, CT scan, how does the tumor is appearing in case of progression or stable disease, etc. So those were judged according to this criteria. Now overall survival, it is defined as the time in months between the CUSP-9V3 induction cycle start date and the date of last follow-up or death of any cause, whichever came first. So the starting to the treatment to the death of the patient or by any cause, may be due to glioblastoma or any other cause. So that is being considered as the overall survival. So patients alive at the time of the last follow-up were censored. Now it's the common practice in the survival analysis. Now they define progression-free survival as the time between the CUSP-9V3 induction cycle start date and the date of the last follow-up progression according to the RANO criteria, or death of any cause, whichever came first. Now patients with no progression and alive at the time of the last follow-up were also censored in this case also. So moving to the next part. So how did they recruit the patients? So they set a inclusion criteria for inclusion in the study. So the eligible patients were adults with histologically confirmed GBM and a recurrent or progressive disease according to the RANO criteria. Now, one thing to consider here is that the primary GBM was histologically confirmed, but the recurrent tumor was not histologically confirmed. They were confirmed by using the RANO criteria. So this is one of the limitations of this study. So the recurrent tumors were not assessed histologically. Next is the patient with prior low-grade glioma were eligible if malignant transformation to GBM was histologically confirmed. Now here, glioblastoma, as we know, there are two categories: primary GBM and secondary GBM. So in primary GBM, these are mostly IDH wild type, while the secondary GBMs, they start as lower grade tumors, grade 2, 3 tumors, and in time they progress to the grade 4, at which stage it is called as a secondary glioblastoma. So this study has included secondary glioblastomas also. In general, the low-grade gliomas have larger overall survival as compared to the primary glioblastoma. So that is also one thing to consider here while judging the particular study. Now, additional eligibility criteria where that the patient shouldn't have had more than 3 progressions of the tumor. So there can be multiple progressions in the glioblastoma growth in the patient's brain. There shouldn't have been more than 3 episodes of tumor progression before. And next is that Karnowsky performance score should be at least 70%. That means patient should be movement-wise. It is Karnowsky performance score. It assesses the status of the health of that particular patient with respect to his mobility. So 100 being the best and 0 being dead, and 50% being a person or the patient requiring assistance of some other individual to carry out his daily tasks and also body functions also. So they have included only those which have Karnowsky performance score of at least 70% of more. So next is the stable steroid dose for at least 1 week prior to the start of the study treatment. Also, with respect to treatment, this criteria was used. And sufficient interval since last treatment, at least 4 weeks for a systemic treatment or surgery, at least 12 weeks for radiotherapy. So that interval they have kept so that effect of some other treatment might not should not overlap with this treatment. So to identify that the effect is clearly due to the regimen being used, they have kept this time gap between the treatment interval. And then next criteria is the no known contraindication to any of the CUSP9V3 drugs. The patient shouldn't have any allergy or adverse reaction to any of the drugs that is being used in this regimen. So how the treatment was given, it is explained by this chart. So at the treatment initiation, the 9 drugs were added to uninterrupted temozolomide. So temozolomide at 20 milligram per meter square body surface area and twice daily. This was continuously given to the patient. And in that background, induction cycle was done in 2 phases. In the first cycle, a low dose of drug was given, and after a gap of 2 days, a new drug was given to the patient. And after some time, they increased the potency of the drug to the higher level. So as you can see here, the temozolomide, it is being continuously given at this dosage level. And at the first day, they start aprepitant at 80 milligram as 4 doses per day. And after 2 days, they start with the next drug at 50 milligram, 2 doses per day. And as we go next, they keep adding each drug into the dose regimen after 2 days interval. So after the end of this day, all 9 drugs are being given to the patient along with the temozolomide. And this is the first phase of treatment, and they start the second phase at these time points. So they increase the dose from 50 milligram to 10 milligram twice daily in this case. And as you can see, different levels of dose increases has been performed in each of the cases. So in this way, the treatment was administered to the patient, and the patient was completely hospitalized during this addition phase, and they were monitored for any adverse interactions and how they are tolerating the drug, etc. Now, after reaching the target doses of all the drugs, the regimen remained unchanged until the side effects mandated dose modification and or a drug pausing, or until the tumor progression occurred. So once all the drugs were administered to the patient, so at that point further the regimen remained unchanged. That means there were no change only in case if there were any side effects that required modification of the dose or stoppage of the drug at that particular time point, only in those cases modifications were done. And the study was locked after the last recruited patient had completed the 12 months of the treatment. So different patients got recruited at different time points. So the last patient, when he received the treatment at the end of the 12 months of his treatment, the study was stopped. The patient without tumor progression continued to receive the first line V3 regimen beyond the 12-month period also. As we can see that there might be some role of this treatment regimen in stopping the tumor progression. Therefore, it would be beneficial to keep giving this drug regimen in the patients in which tumor progression was not observed. So this regimen was continued beyond 12-month period in those patients also. Now, as the main aim is to judge the safety of these drugs, so they also assess the safety and did appropriate dose modification also. So cumulative toxicity of the regimen was assessed. So as we have seen earlier, that they started with one drug and at the interval of 2 days, they added new drug. So what was the cumulative toxicity for each patient? They kept assessing that as we have seen the patient was hospitalized also. And the side effects most likely to occur during the treatment, they were identified by employing the summary of product characteristics of each of the 10 drugs. So each 10 drugs has its associated side effects list. So by using that, they have identified what are the most likely side effects that would occur to the patient at that particular time point. So they also assess patient for the side effects. And a strategy was elaborated for those modifications and those re-escalations and on hold. So they formed some rules like in what condition, what intervention would be followed. An example is given is that fatigue is a side effect if patient is having fatigue. And if there is a grade 1 and grade 2 fatigue, then there would be no action taken, no change in the treatment regimen will be performed, as the grade 1 and grade 2 are mild symptoms. But if it goes to the grade 3 fatigue, in which it starts to become serious, then in that case, all the list of drugs, 9 drugs that we have, the drug that is most likely to cause the grade 3 fatigue in that particular list, that particular drug will be stopped. The drug at the top for that particular side effect, it will be stopped. And they will stop it until the grade 3 fatigue, it resides to grade 2 or lower. And again, falls back to the normal level. Then they will stop that particular drug. But if it does not subside the fatigue from grade 3 to the lower level, then the next drug that is likely to cause that particular side effect, it will be stopped. So in this way, they have devised a strategy how they will treat the 9 drug combination to assess the side effect. Now next is how they are going to assess the response by neurological examination and contrast enhanced magnetic resonance imaging, MRI. So by using RANO criteria, as histological assessment is not possible in this case. So therefore, the radiological characteristics according to the RANO criteria were assessed for assessing the response of the treatment. Then assessment was done at week 6, week 10, and then every 8 weeks. So at this time points for each patient, they have assessed the response of the drug regimen. Then the best overall response, that is the best response recorded from the start of the treatment, was used as a secondary endpoint. So as we have defined that the secondary endpoint, that the primary aim of this trial is to assess the safety of the combination of this drug. But as there might be possibility that efficacy can also be assessed. So in that case, the secondary endpoint was set from the best response from the start date of the treatment. The next, what they achieved in this particular trial. So the patient characteristics, that they screened 12 patients, but out of these 12 patients, one patient could not be included because it showed high serum transaminase in its laboratory report. So it suggests kind of a liver problem. So they did not include that patient because we are using multiple drugs simultaneously. And then another patient was not included because he had acute deep vein thrombosis. So due to that, the patient was excluded from the trial. And so only 10 patients were included in the studies. The sample size is very small. They have continued with the study. Now this shows the characteristics of the patients included in the study. So 60% of the patients were male and 40% female. Then the 80%, that is 8 patients were primary GBM and 2 patients were secondary GBM. That means those progressed from the lower level glioma to the glioblastoma. And the Karnowsky performance score for patients, the start of the treatment. So 4 had 100, 2 had 90, 80 had 170. Sorry, 3 patients had KPS as 70. So as we can see, they have identified different characteristics for the patient. Then the location of the tumor was also studied, the position, and then the what was the initial extent of the resection, gross or complete resection, like maximum resection was possible, or it was not possible. So maximum resection was possible in 7, that is 70% of the patient. They also assessed the MGMT promoter methylation status. This is a criteria for response to temozolomide. So hypermethylated patients, they show a better response to temozolomide. This is also a significant criteria to consider in this particular trial. So 60% had hypermethylated MGMT and 40% had non-hypermethylated. IDH1-2 status. So as we can see that the secondary GBMs, 2, they were IDH1 or 2 mutated, and while the rest 8, that is the primary GBM level. So prior therapies that were given, surgery, radiotherapy, temozolomide, bevacizumab, tetrahydrocannabinol, and tumor treatment fields. So these were also identified. So only these different non-standard treatments, these were given to only 1 patient out of the 10 patients that were recruited. Now, for safety, for assessment of safety of the patients, so what they did. So they had defined a POCOX type safety boundaries for stopping the trial. So none of the boundaries that were set for this safety assessment were crossed at any time. So what does it mean is that at what level are they going to stop the trial? If more number of patients have very adverse effects of this trial, this drug regimen, then when are we going? What is the cutoff for that? So they have set different cutoff levels for 10 sample patients, and they report that none of these boundaries were crossed. That means the study could complete without any disruption for these patients. The 9 patients completed at least 2 treatment cycles. So in the entire study, so only 1 patient did not complete 2 treatment cycles. So at the end of the second treatment cycle, no patient had experienced any unmanageable grade 3 or 4 toxicity. So this is the point, that grade 3 or 4 level toxicity was not found in this study period in any of the patients. And all patients had received at least 7 of the 10 drugs given at more than or equal to 50% of the target doses. So out of 10, 7 patients, out of the 10 drugs that were given to the patient, so all patients had received at least 7. So rest of the drugs, they might have shown some adverse effect in the patient, so those might have been stopped. But 7 drugs were given to all patients in common. And the primary endpoint of this study, that was to assess the safety of this combination of drugs, it was met, because there were no grade 3 and 4 toxicity. Now, what are the drugs those were paused? As we have seen that 7 drugs, they were given to all of the patients. So the most frequently paused drugs, they were ritonavir. It caused ataxia and fatigue in the patient. Temozolomide for diarrhea, nausea, laboratory, other laboratory abnormalities, the blood reports, etc. Captopril for diarrhea and nausea. Itraconazole for diarrhea and laboratory abnormalities. And most frequently dose reduced drugs. These drugs were not stopped, but their dose level was reduced. These were ritonavir and Captopril. The results were for gait disturbance and for fatigue, respectively. Now, this table shows what were the adverse events that were encountered in the patients. So there are adverse events of fatigue, nausea in most of the patients, then headache, seizure, lymphocyte count decrease, diarrhea, dysphagia, gait disturbance, bradycardia, tremor. And the drug to which these adverse criteria were ascribed. As we can see, most of the grades fall in the grade 1 or 2. Very few are falling in grade of the grade 3 and 4. And most likely those drugs were stopped for those patients. So this is again more list showing what were the adverse events that were encountered by the patients. So liver and pancreatic enzymes, these are the transaminases whose level was increased in the blood count, which shows some liver problems. And these are the associated drugs which were stopped. And these are the list of the drugs in which this particular side effect is known to occur in the patients. So there are different levels, hematologically, lymphocyte count decrease, white blood cell decrease, platelet count decrease, etc. These adverse events were also recorded. Then central nervous system related adverse events were aphasia, ataxia, confusion, edema, gait disturbance, etc., etc. And as we can say, the number is less, except in this case, gait disturbance was observed in the 5 patient, and the drug which was attributed, it was sertraline. Then gastrointestinal symptoms that those were identified were dysphagia, nausea. Other symptoms that those were identified were fatigue, hypotension, lung infection, muscle weakness, and thromboembolic events. So these were also less in number. So the efficacy of the regimen, what was the efficacy of this drug regimen in the 10 patients? So best overall response was stable disease in 6 patients and progressive disease in the 4 patients. So that was the overall response that was identified. So this table describes the criteria and the response for each of the patients. So this gives us a patient ID, the age of the patients. So age ranged from 25 to 60. Then, as we have already seen, that the Karnowsky performance score was that was acceptable was minimum 70 and more, and the prior treatment that was given to the patient. Then the MGMT promoter methylation status and IDH1 mutation status. So 2 patients have mutated IDH1 or 2. That means those are progressing from lower grade to the higher layer. Now, what is the best response? Either it is the stable disease or progressive disease. Stable disease means that there was no growth in the tumor, was assessed by using the RANO criteria radiologically. And in progressive disease, that means there was progression, recurrence, start of the growth of the tumor. And progression-free survival, in this case, starts in months. It ranges from 0 to 29 months. and these are the vital status of that particular patient. So as you can see, 5 patients were alive at the end of the study, and the other patients were deceased. Now, how did they find the efficacy of the regimen? So median duration of the response was 8 months in responders at the time of the data lock. That means when the last patient it completed the 12 months of the regimen administration, at that particular time, the median duration of response was 8 months, and it ranged from 1 month to 11 months. And for 5 patients, stable disease were ongoing at the time of reporting. When this study was reported for publication. So for 5 patients, the disease was at a stable state. Now, 3 patients developed no detectable tumor on MRI during study treatment, but would not be assigned complete response according to Dano because their tumor was non-measurable on MRI at the study end. So these 3 patients, these were non-accessible as responding or completely responding because their tumor was already non-measurable at the start of the study on the MRI. Then both progression-free survival and overall survival at 12 months were 50% with large confidence intervals because of the small sample. Now, overall survival and progression-free survival of 12 months at 50% is very high. In generally, in the GBM cases, it is around, it is very low, 20%, 30%. But here in this case, they have got 50%. Now, the primary aim of this study was not to assess the progression-free survival and overall survival effect at a high level because it has a very small sample size, and also the primary aim was to assess the safety of the drug combination being used. But still, whatever results they have got, they show that 50% overall survival and progression-free survival were observed at 12 months, which is also a very encouraging result. Now, this chart shows the progression-free survival, and as you can see, the 5 patients that got deceased, and after that there was stopping of treatment, follow-up. So here also we see the overall survival of the patients in the CUSP-9 V3. Now coming to discussion. Now the 9 carefully selected non-oncological repurposed drugs together with the twice daily 20 milligram per meter square body surface area temozolomide was found to be safe and generally well tolerated if the individual dose adjustment were performed. So as a result of this study, they have found that these 9 drug combination plus temozolomide was well tolerated. But as we have seen, not all 9 were tolerated by each patient. So there is need of individual specific dose adjustment. Some drugs needs to be stopped. Some drugs, their dose needs to be reduced according to the adverse events and the side effects that the patient is showing. Next, the CUSP-9 V3 is well enough tolerable to be started in outpatients and to be fully introduced over a shorter time period than the 35 days that this study has used. What they are saying is that as the safety is evaluated in this case, so this regimen can be started in the GBM patient as an outpatient basis because it is well tolerated. So the most frequent adverse events are not expected to cause management problems as they are well known to physicians treating patients with recurrent GBM. As we have seen that most of the adverse events were grade 1 or 2 in the mild category, and these are also well known to the physicians who treat the recurrent GBM. So therefore, these are not expected to cause any management problems, even if you are using 9+1 drugs. So again, in this drug trial, 5 patients progressed quickly, and they died within the range of 1.5 to 7 months. And other 5 patients that survived, they did well on the treatment. And all of these 5, they have progression-free survival of 12 months or more. At the stop of the study or lock of the study period, still these patients were on the same regimen. So this is also encouraging result this study has found. So next, the small number of patients they prevents any interpretation of the efficacy of the CUSP-9V3 regimen. So only alternative for that will be to use larger number of patients recruit and do the study for the longer period of time. Now, what is the impact of this? Now, the first important finding that we have from this research is that the study shows that it is possible to use 9 different drugs.
Vijay, can you please speed up?
Yes,
the
yes.
time is.
These are some of the last slides. So they can be used safely, and also there was no very high level toxicity to these drugs. Then as these drugs are targeting different pathways in GBM, so the precision oncology pathways can also it is beneficial for precision oncology field that we have large number of drugs available to treat the GBM patients, and this might result in the difference in the survival of the patients. Then the treatment regimen was found to be safe under the clinical laboratory and electrocardiogram monitoring during the study period. Now the next step would be to carry out a multi-center randomized control phase 2 and phase 3 trial, and it is in preparation by the study group, and they will start that also. And this pilot study, it met its primary endpoint and with no unpredictable side effects resulting from the combination of drugs, and there was also indication towards the positive impact to the patients also. So that's the presentation. If there are any questions, I'm open to the questions.
Thank you so much, Vijay, for that enlightening session. I hope all of you enjoyed it. So I guess there are some questions. So one question is from Nupur Biswas. So does these drugs work irrespective of genetic divergence of the patients?
So they have not assessed molecularly the tumors, like what pathways are mutated or activated in the patients. So these treatment or these drugs are kind of molecular signature agnostic. So it does not affect, so these are commonly used drugs, and they are known to affect some certain cancer related pathways or affect the cancer cells in some ways. So the overall aim is just to target multiple pathways simultaneously, so that there will not be any evolution of these cells and turn it into a treatment resistant.
Actually, my question was that we know glioblastoma is highly heterogeneous disease, right?
Yes.
So that's why its treatment fails. So some drug works for patient 1, but that does not work for the patient 2. That's why I asked whether these drugs will work for all types of patients. They did not mention their genetics. Suppose that IDH wild type mutation, there are different genes we know gets mutated, different types. So that's why I asked what is the genetic divergence of the
they
patients.
haven't taken the genetic characteristics of the tumor.
Yeah, that's
the individual also.
Important. Yeah, I felt that is important. And also I think the number of patients is too low, 10 only, for drawing any conclusion for the future perspective.
Right.
Yeah, that's a comment, of course. Yeah, you did not do the experiment.
Of course.
So you don't have the control there, but I just comment that 10 is a too low number.
It depends upon how many patients you get.
Glioblastoma is not a rare disease, of course. So still that respected.
Might be. There might have been some reasons that they did not get the patients.
Yeah, that is hard to take.
Right.
Okay, anyways.
Maybe the stage 3 and 2 and 3 trials might give some idea about the efficacy of the treatment, because preliminary there is some efficacy that is being shown.
Yeah. I'm not raising question about the efficacy, but the number of patients is too low. Even if it is good, yes, for these patients, it may not be. Statistically, it's very poor. Yeah, that's the thing.
And also other part is like 2 of the patients are progressed from the low grade, so they generally progression-free survival and also overall survival. So that might affect the statistics that they have come up with.
Those things will happen in any trial. That's why people should record large number of patients.
Yes, right.
Okay, thank you so much, Vijay, for that enlightening session. Hope you all could benefit and learn about glioblastoma. So thank you all so much. I hope you guys enjoyed the session. So today's Cell Talk is over. All the best and have a great day.
Thank you. Thank you, everyone.